All right, so my name is Niani Junair. I am the Legacy Cancer Healing Center Coordinator, and we are lucky enough to be joined by Dr. Sage Bolte. She is currently the president of the Innova Health Foundation in Falls Church, Virginia, and previously served as the executive director of Life with Cancer and Patient Experience for the Innova Shar Cancer Institute. She is known nationally for her work in sexual health and cancer and is respected as a leader in the field of oncology social work. Her PhD dissertation explored the impact of cancer and its treatments on the sexual self of young adult cancer survivors. We are very pleased to have her share her wisdom and her research today, and a big thanks to the Legacy Health Foundation for sponsoring this event. So thank you.
Yeah. So thank you all. I am on the West Coast, so it is evening there. I know you're just starting I'm on the East Coast, you're on the West Coast. I'm on the East Coast, just starting my later evening. I know you're just starting your early evening, and I appreciate you taking the time to be with me tonight. Just a couple of ground rules. As discussed, we are recording this, and we are going to hold questions until the end, but I do encourage you to write them down as we go along. And if I answer them along the way, you can cross them off. I'm sure there's going to be plenty of time for us to answer any questions you may have. And I also want to offer that there is no question that is either wrong, dumb, not important enough to ask or bring to the table. So please know at the end of this, we look forward to having a candid conversation. Until then, I hope that you find this information helpful for the healthcare professionals who watch this. I hope this begins to increase your comfort in having conversations with your patients. So thank you all for joining me tonight. You know, what we talk about sexual health, and you'll hear me use the words sexuality, sexual health, sexual self, somewhat interchangeably. The word sexuality for me often gets misconstrued with sexual orientation. And so I try to talk more about your own sexual health, because that allows you to define whatever that means for you. And we know that being diagnosed with cancer is a life-altering experience, whether it's an early stage, a late stage, whether you're single or in a relationship or relationships. It changes the way we interact with our body, the way we interact with our partner or partners, the way we interact with our community. And that in and of itself can create some new and interesting barriers as we learn to get to know our bodies again. And sexuality and intimacy are critical pieces of quality of life at all stages of life. So again, whether you're 22 or 82, your sexual health and sexuality and intimacy are just as important regardless of your age or stage of life. And it's just as important if you're in a relationship to your partner as well. Tonight, we're going to talk about, obviously, defining sexuality between the sexual self and intimacy. We're going to look at 3 ways, at least 3, that cancer and its treatments impact the sexual self, and then identify at least 3 evidence-based interventions to improve your sexual health and intimate relationships. And some of these may not be new for you, but I hope that I can add a little bit more context or give you some additional information related to it, or again, in our time in Q&A, when it's not being recorded, have a candid conversation about what other things might be helpful to you as you get to know your body after a cancer diagnosis and your sexual body and your intimate needs after that. As I said, when I think conceptually about that word sexuality or sexual health, I think about the sexual self, and I can't help it. I'm a social worker by training. I come from a cognitive and behavioral theoretical background. So I always think about how the way we think about ourself or ourselves influences the way we feel about ourselves, and that influences our behavior. And the way I put this in the context of cancer is, you know, when we think about many aspects of our lives, when hard things have happened or really great things have happened, that influences how we handle other hard or exciting things. And so if we're coming into a cancer diagnosis with an already distorted or negative view of ourself and our sexual self, certainly that often will lead to further demoralization, feelings of depression and anxiety that then influence our sexual feelings. We might not feel as aroused. We may not feel as attractive. We may not want to be as physically intimate. And those behaviors, being intimate, being sexual, engaging or initiating sex might decrease. If we come in to a cancer diagnosis and we've faced challenges in the past, for example, and learned how to navigate challenging things, or maybe we've been in a long-term relationship and have had to navigate some changes that happen as we age or as we have kids, we might be more able to tackle some of the challenges that cancer poses to our sexual selves, like erectile dysfunction, and how we navigate that in our relationship, or how we navigate that individually and what that means for you, how it defines who you are, and how you navigate what that brings up for you. And again, that could lead to feelings of confidence that there are hard things I've navigated in my life and I can manage this. And even if my erection doesn't get as firm as it used to, or it doesn't get firm, my penis doesn't get firm at all, I can still be sexual. I can still be attractive. I can still feel sexual feelings. And therefore, I'm still initiating in sexual and intimate behaviors. So again, the way we think about ourselves, our thoughts influence our feelings, which influence our behaviors. And that's the construct that I'm going to give some of the tips I talk about on how to manage some of the challenges we face after cancer diagnosis in that construct. We also know beyond that it's a quality of life issue, as I said before, there's actually quite a few studies that talk about the quality of life. And I go back to as early, this is as early as 2002, and certainly there are studies way prior. But we do know that quality of life studies have indicated that this is sexuality, and altered sexuality continues to be a concern for many survivors, and that it can be both high and persist for years after a diagnosis, where something like nausea or fatigue that might be high early in a diagnosis and through treatment, and even fatigue being a complaint for a year or two over. We notice that those start to dissipate as quality of life challenges, but sexual health, sexual function remain highly prevalent and a significant concern for many cancer survivors, regardless of their diagnosis or treatment years after the diagnosis. And we also know that alterations in one's sexual self, one's sexual health, can impact not just the person diagnosed with cancer, but their partner or partners, how their partner is received or perceived, some of the partner's own concerns or fears about what this might look like for them as a partner. We also know that, again, across the diagnosis, across the spectrum of cancer diagnoses, that 10 to 100% of people diagnosed with cancer will experience some form of sexual dysfunction. And that seems like a massive spread, 10 to 100%. It pretty much means everyone. But I want to explain that a little, because if we think about not just the physiological impact that cancer and its treatments can have, but also the psychological and the social impact that cancer and its treatments can have. Having increased depression or anxiety and then being prescribed something that manages that depression or anxiety can have a negative impact on sexual function for many people. So again, it's not just the cancer diagnosis, but some of the side effects or some of the medications we prescribe that alter sexual function for some of our survivors. When we look at some of the diagnoses that we know are directly correlated with sexual dysfunction, and I'm going to use that word right now, sexual dysfunction, so people that report distress or changes in their sexual function. We know that hematological malignancies, specifically those who have had a stem cell transplant or a bone marrow transplant, do report higher incidences of changes in sexual satisfaction, sexual function. For some men, they might report a noticeable change in their erection or the firmness of their erection, usually related to hormones being impacted. For prostate cancer, again, I think these statistics are probably a little low. But we know that the majority of men have some concern or complaint related to their cancer diagnosis and the impact on their sexual health. Bladder cancer, colorectal cancer, head and neck cancer, and certainly there are others that are continuing to be studied that we know have direct and indirect impact on one's sexual health. These are more the direct impact, so the surgical treatments we use to treat these cancers, the types of chemotherapeutic interventions that we provide, and then the radiation treatments that we provide often have a direct impact on these cancer diagnoses and on the persons diagnosed with those cancers. So when we think about how cancer impacts relationships and the sexual self, I'm going to talk about intimate relationships, both intimate meaning emotionally and physically intimate, but also we can explore that as how it relates to your non-sexual intimate relationships and how navigating those new relationships can be challenging, as well as you're navigating your new body, some of the side effects, fatigue, etc. So let's start with the etiology of altered sexuality related to a cancer diagnosis. As I mentioned before, there are cancers themselves, cancers of the sex organ, or cancers that are related to the nerves that could be impacted, directly related to erectile function or anal function, and certainly can impact sexual function. There's also psychological distress, as I named earlier, that can be associated with both the diagnosis and the treatment for both the person diagnosed with cancer and partners. If you have a partner that has experienced significant anxiety or, again, depression related to your diagnosis, which is not uncommon, and they've been prescribed a medication like an SSRI, that could be impacting their sexual function as well. But also in general, stress and distress impacts people's sexual health. When we aren't able to relax or stay in our body or stay present, certainly that's distracting, and it creates some challenges for us to be fully present in our sexual bodies as well in a sexual relationship with a partner. We know that different therapies that we receive during a cancer treatment can result in different alterations, and we'll talk a little bit about that. But radiation to the pelvic region, when there is potential for nerve damage, changes in the pelvic floor, which can also impact both bladder incontinence as well as rectal or fecal incontinence, that can create some stressors for individuals. We know that chemotherapy can create some challenges. As simple as a thing, even though it is very frustrating for those who experience it, as neuropathy. You know, if you are consistently distracted by the pain in your hands and your feet, it's really hard to focus in being sexual, especially if you're already anxious about how you might perform, or if you're having erectile disorder issues, or you're having low libido. The simple side effects like dry mouth or neuropathy can have a tremendous impact on how you feel in your sexual body and how your body responds sexually. Certainly, we also know that alterations in relationships during and following treatment can impact one's view of oneself, one's view of one's sexual body, how one interacts with their sexual body or interacts with their partner and their sexual body or their own sexual body. And when there's stressors, that can exacerbate distance. It can exacerbate the interest in or lack of interest in being sexually intimate with your partner. And it could impact directly just intimacy, the closeness of one another, because as we said early on, sexuality and intimacy are a quality of life issue. They are not a life or death issue. We all know that, even though sometimes they may feel that way. It certainly is, it is a significant impact on connectedness, and intimacy is a human need. It's that need for connection, feeling safe, the ability to be vulnerable. And we have those in relationships that are sexual and relationships that are non-sexual, or both. When we look at the physiological alterations that many men experience, and again, I am certainly stereotyping to get a general information. So everybody has different experiences, but we know that there are some specific treatments that can impact. So the neurovascular damage resulting in erectile disorder. So chemotherapy agents, radiation, surgery that's directed towards, again, the pelvic floor, the prostate, the bladder, the colon, the anus. Those can certainly directly impact erectile function. We also know that hormone changes, endocrine changes, can increase sexual alterations in men, including decreased libido or interest in being sexually intimate. We know that hormones are connected to osteoporosis, vasomotor flushing. And why do I include those in a sex talk? Actually, because people have come to me and said, I'm osteopenic. I'm afraid of the brittleness of my bones. I'm afraid of heaviness or pressure on them. And so really some of that, again, isn't necessarily linked to sex, but can be if there's concern or worry that certain sexual positions might put you at risk for hurting yourself or a break. For those who have metastatic disease in the bones, some people are worried that it might create pain or, again, a break. And so that can create some challenges as you redefine your own sexual relationship and certain positions that you may or may not feel comfortable in. We know that penile atrophy is a common side effect, especially for, again, those who have had pelvic floor radiation or had a prostatectomy or have a reduction in hormones. Infertility for some can create distress, and not for all, but for some, even if they're not even wanting to have children or had no desire to have children, the fact that it was taken and it wasn't a choice can affect some men's view of their masculinity. We also know that simple side effects, as I said before, fatigue and decreased physical stamina. The reality is being sexually active, whether it's masturbation with yourself, sexual fantasies, or sexual activities with a partner or partners, requires some stamina. And it does require physical activity, physical action. And so if you are significantly fatigued or you have decreased physical stamina, you might have lower interest or lower tolerance to continue to engage in sexual play with yourself or with a partner. We know that for men who were treated as a young man, as a child, especially those who were treated with a brain tumor, that they might experience delayed or absent puberty, which have different complications later on in life related to their sexual function if they're diagnosed as an adult again or have a secondary cancer. And for men who engage in anal play or have anal sex, there may be limitations or a substantially altered sex life depending on your diagnosis and treatment. And this has a different level, I will just name, this has a different level of grief for many men, specifically men who engage in anal sex as their regular sexual intimacy or play. Because it becomes really challenging if a penis isn't rigid enough or firm enough to penetrate the anus. So I just want to name that up front because I think sometimes we're more dismissive, and I think it's important to just name that there is loss in all of this, but for those specifically. So why don't we talk about sex as much as we should? And I think, to be fair, for those of you who've been diagnosed with prostate cancer, I think we've gotten better about talking about it up front because it is so significantly correlated with your ability to have sexual function in the way that you might have before. And so it's addressed as a side effect. I still think we can do a lot better, but we're doing better at addressing it, hopefully, before the diagnosis, talking about what you can do to be as preventative as possible and working towards penile rehab. But we don't do it for a lot of other cancer diagnoses. In fact, we're fairly dismissive of it in other diagnoses. And then that leads to a subtle, unintended message to our patients that maybe this shouldn't matter. Maybe, I should just be happy that I'm alive, or they saved my life, or I should just be happy that I have enough of an erection. And I just want to validate for all of you, this is a loss for you and your partner or partners. It's not something that you asked for. It's not something you wanted. And it is something that was taken for you. And there are lots of ways to get creative about how you can continue to be satisfied in your sexual relationship, satisfied in your intimate relationships, But I think without acknowledging the grief and loss and the stress that it can cause, it doesn't validate the journey that you all are on or have been on. And that speaks to the emotional distress. We know that a cancer diagnosis in general creates 15 to 25% higher distress levels than those who don't have cancer. So automatically there's a level of, even if you have a curative cancer, there's still, for so many people, the first thought is, am I going to die? Or is this going to come back? And so that added stress creates stress on our bodies, right? And stress on our bodies typically impact our sexual function. It impacts our relationships. It impacts our ability to focus and concentrate. It impacts our ability to thrive at work or thrive in relationships. So addressing distress needs to come before we address sexual function if distress is creating some of the challenges you're having. Additionally, that comorbidity of mental health or social challenges, right? If we think about Maslow's hierarchy, we need kind of our basic needs. So housing security, food security, relationships and intimacy, those are really important and a foundation. And if some of those are broken, we need to address those first as we build up to the other needs and helping you reclaim and regain your sexual self in whatever new definition that might look like. Certainly after a cancer diagnosis, there's an increased sense of vulnerability, no matter what our age. We have a different relationship with our body. We have a different relationship with our doctors because they've seen a lot of our body, and that can be challenging as well. We certainly know that men do experience body image challenges, a decrease in self-esteem. And again, I will say, as healthcare professionals, we aren't always as in tune with the impact of that on men than we might be normalizing for women who, for example, lose a breast. And so, if you are noticing that you're struggling with body image changes, whether that's because of weight gain or weight loss, because of some of the challenges that come with both of those, because of just the scars or changes in your body, atrophy, etc., I'd really encourage you to be bold and to seek out support for that, because there are a lot of techniques we can, with cognitive behavioral therapy and others, really work to help you reclaim that sense of self and security and confidence. And again, as I've mentioned, there are other connections, relationship challenges, partners, health and emotional reactions, the losses you both experience as a couple, as a family, can certainly continue to impact your own sexual health and view of your sexual self. And we know this study, I use this in every lecture I give. So if you've ever seen one with me or you see another one in the future, I use this a lot because I always like to point back to the fact that it was in 1999 and that we haven't come much further. This was asking, why aren't patients talking about their sexual health needs with a provider? And much of this hasn't changed. The numbers have gone down a little bit. I find with our younger generation, they're a little bit more willing to ask questions of their providers. Doesn't mean their providers are that much more comfortable talking about it, but they're asking more questions. But the thing that still continues to bother me the most is that last part, that 76% of people felt that there was no treatment to treat their existing sexual dysfunction. So why ask? And, I think if anything comes out of our time together tonight, that you find a glimmer of hope or maybe some additional resources to reclaim that and maybe rethink that if you've tried a lot of things and you've felt discouraged, maybe there are still some ways you can explore. And whether it's through a professional like myself, a urologist, an endocrinologist, a pelvic floor therapist, your MD, that there might be some additional tools and tricks that we just haven't tried that might work for you. So what do we know are the most common forms of sexual dysfunction in men? Many of the ones I named. We know erectile dysfunction is the #1 complaint for men. And I want to carefully define erectile disorder or dysfunction, because oftentimes it gets kind of classified as the inability to get an erection. And certainly that might be a part, but there's really a scale, if you will. So even if your erection has changed and it's not as firm, or your penis has changed in length or girth, And that's distressing to you, and that's creating some challenges for you to feel satisfied, sexually satisfied. It might lead to ejaculatory disorder and the inability to orgasm. But that number one complaint is erectile disorder or dysfunction, which often, again, in the other category, can be paired with having sexual bother. Just, I'm frustrated that I'm not interested. I'm frustrated that my body's not working the way it used to. I'm frustrated that I'm not feeling satisfied. As I mentioned before, orgasm or ejaculatory disorder. And again, that reduction in penile length is a high report of distress for many men. Before the tiny blue pill, and I'm going to talk a little tongue-in-cheek with this, because as a sex therapist, as much as I appreciate our that how far we've come with science, and that we have come so far in creating an opportunity through medication that helps with addressing a very distressing side effect for men, I also feel like it's limited additional conversations that used to happen before we had PDE5 inhibitors, which are just looking at some of the most effective interventions related to when somebody struggles with erectile disorder. So we know that counseling and education are the most effective. Now, counseling and education with intervention, whether that's the use of a pump, whether that's the use of hormones, whether that's the use of Viagra or a tiny blue pill, all of those are in great combination with one another. But sometimes we have found, well, not sometimes, we have found in research that education and counseling have significant impact, because often, again, if we know what our expectations are, we can be educated on how to manage what the new normal is, and we can support ourselves emotionally through the changes. We're going to have better satisfaction, even if the erection doesn't go back to what it was or isn't even close to what it was before, with education, normalization, and finding new ways to use the erection you have or don't have, and finding sexually satisfying ways to connect with yourself or a partner, again, can be highly satisfying for many men. One of the other things we often neglect and is important to consider is what are the partner or partner's wishes and desires as well. You know, certainly we can prescribe a pill, we can give you a penis pump, and we can send you on your way to getting a firmer, better erection. And if you have a partner that isn't interested in engaging, that is a challenge in and of itself. So that's that desire discrepancy, or a discrepancy between what you both want. Now, that doesn't mean with the tiny blue pill and a penis pump, you can't have a great masturbatory experience or a sexual experience with yourself, or maybe with your partner nearby. But we do want to make sure that as we are prescribing or having conversations around managing expectations, managing stress, managing sexual dysfunction, that if you're in a partnership or partnerships, that we include him, her, or them in the conversation, so we level set on what each of you expect, and so that each of you can participate in what brings you joy and desire, or joy and satisfaction. Also assessing expectations and practices. You know, what is it that you hope to get, and is it realistic? And if it's not, let's set some goals that are. Do you hope to be able to regain the ability to have anal sex? If you can't, what are some other ways that you found pleasure? Is oral sex a possibility? Is using toys a possibility? Again, do you expect for vaginal penetration? If that isn't possible, are there other ways that we can help you gain pleasure for both parties? And having those conversations with a therapist can be really helpful. Understanding some of the causes and contributors of erectile disorder is certainly critical. You know, knowing what creates some of those challenges, again, related to education, can be helpful. Education is empowering. It helps us feel less alone. It normalizes. It gives us some statistics on what we can expect, and can be very helpful. Some of the other components that we talked about, I talked about SSRIs and their impact. That's those medications we use to prescribe for depression and anxiety. One of the few medications that seems to actually counter sexual side effects and help improve, that also helps address mood, is Wellbutrin. So if you are on an SSRI, it may be worth talking to the psychiatrist you're seeing, or your primary care, or your MD who's prescribing it, and having the conversation about the value of changing to something that might not have as significant of a side effect, and whether that's just delayed ejaculation, whether that's impacting libido, whether it's impacting erectile function. It's worth a conversation with your physician. And that goes with all your medications. It's often, there are many comorbidities, heart medication, gabapentin or other medications we use to treat neuropathy, things we use, steroids, things we use to treat side effects. So really, if you're having frustrations and you've tried things and you're just feeling like you're not making the progress you hoped, or you want just a fresh eye on, do any of these medications interfere with my ability to achieve some of my sexual health goals, again, with the understanding of what is realistic versus what used to be and what may now be normal now is important. And then, knowing that there are options for physical therapy. There are pelvic floor therapists out there who are trained physical therapists that focus specifically and only on pelvic floor. They work with men who are concerned about bladder incontinence or fecal incontinence, and can really help with teaching techniques that can help decrease those issues for people. Additionally, a referral to a urologist, if you're not already connected one, an endocrinologist for a review can also certainly be beneficial. We do know, as I mentioned, that PDE5 inhibitors certainly are so helpful, and we have seen great improvement in men's ability to get and maintain a satisfying erection, especially again in unison with a vacuum pump and a cock ring placed at the base of the penis to help blood flow retain. You cannot use a penile pump or a cock ring if you are on blood thinners or have any risking of clotting factors. So if any of that is a risk factor for you, or you are on blood thinners, you shouldn't use it, and make sure you talk to your doctor about what your options are. Again, we can prescribe medications that help, but I want to again draw our attention to what's up here is almost more important than anything else. So if we're finding ourselves unattractive, if we're frustrated, if we're fighting with our partner or partners, and we're finding ourselves less attracted to our partner or partners, we can prescribe tiny blue pills until the cows come home, and it's not necessarily going to address your erectile dysfunction, because addressing what is up in your mind is as important as addressing what is happening with your erection. And that goes for libido, right? The PDE5 inhibitor doesn't increase your libido. It certainly helps with blood flow and increasing your erection, which can then instigate or initiate greater interest, or a feeling of horniness, or a feeling of interest. But being interested, having libido, feeling horny, a lot of that is up here, and it's further instigated through just touch, kissing, some of those things that we might do when we're first getting to know our partner, like long makeout sessions. Those can be really helpful, because the more that you include that, the more your body's going to respond to the stimulation and the interest, and your head also has the ability to do more fantasy. It gets more involved. So that can also be important to remember. We also know that injectables are certainly an option and can be used again in combination with other techniques, and can be very helpful. For many men, it's not bothersome. It feels like a small prick, and the benefits are great. Again, finding what works for you is most important. And so some of that has to do with spontaneity and your interest in spontaneity, your willingness to introduce other toys or devices into your sexual play, again, with yourself or with a partner or partners. And those are important to make note of. Certainly there are greater interventions that are more permanent, like a penile implant, which are always worth exploring. If you're just you're continuing to feel discouraged or not satisfied, worth exploring with a surgeon. They are permanent. There's always risks with them that you should talk to your physician about. There are risks for nerve damage. Again, they really try to minimize that. There are other risks associated with it, but certainly something that is a resource for men to explore, that I know many men who are highly satisfied with that choice, and other men who have found great satisfaction without going to an implant. If testosterone therapy is allowed based on your diagnosis, really important, again, to be closely followed and have regular labs for evaluation, just to make sure that your body isn't naturally recovering or you're not getting too much, but also just to have eyes on it, ensure that you're on the right dose. We do know that just as you might notice as your hormones have dwindled or been permanently reduced, you might notice that your mood is a little lower, or your mood is shifted, your libido is lower, your erectile function may be changed. So certainly hormones, testosterone can impact those and improve those if you're experiencing any challenges. And again, the combination of therapies are often what work best. And early and often is also what works best. So even if you are not sexually active with someone else, and you are sexually active with yourself, using these techniques for continued stimulation, for continuing to keep that muscle as strong as possible, stretch and strengthen techniques of the penis are really important. And there are some techniques I believe are listed in the American Cancer Society, Sexuality in the Man with Cancer and His Partner. But the stretch and strengthen exercises for men, especially following prostatectomies or prostate cancer treatment, is really a daily exercise of stretching, pulling the penis away from the body, allowing it to stretch, and strengthening, which is using the Kegel exercises, that muscle that we use to stop the urine flow midstream. That can be really helpful. And that's where pelvic floor therapists also come into play, where they can really help you. If you're feeling like it's too weak or you're not noticing how to stop it, they can help you with some biofeedback. When we talk about low desire, some individuals have no issue. It is not distressing for them that their desire has shifted, that they don't find it distressing, that they're not as interested in sexual play. They found other ways to find intimacy or closeness with their partner or partners. They find other things that they've found together that they feel very bonded with. And so when we talk again about low desire as a disorder, it's really only a disorder if it's distressing to you and or distressing to your partner. I say this both for you all, but also for any of the healthcare professionals that might watch or learn from this. There is a correlation with changes in sexual desire or disconnect from the sexual body if there is a history of trauma. And so being aware, if you have a history of sexual trauma and you would be willing to share that with your care team, it is really helpful and important for them to know so they can show up for you in the most supportive way possible. We also know that for low desire, again, low desire often is connected to stress, distress, or hormone changes, that if it's distress in a relationship, treating those relationship issues is really critical. Also, setting expectations and redefining what libido is, what interest looks like. Oftentimes, I'm going to gender and stereotype, so please give me some grace. Oftentimes for men, the message they were given as young boys was if they get aroused, they get an erection. And if they feel attracted to someone or desire someone, they get an erection. And when an erection is no longer possible or has significantly changed, there is then an association that I must not be aroused or I must not be attracted. And we have to rewire that to attraction has little to do with whether my penis gets hard. And desire has also little to do with whether my penis gets hard. It's really up here in our mind. What are we thinking? What are we desiring? What are we wanting? What are we enjoying? Can we feel the sensations that bring us pleasure? Can we enjoy those sensations? Can we sit with them Can we still enjoy the sexual body in the way that it is able to work now and get pleasure from it, even if it looks different, even if my erection looks different? So shifting that body response to a brain desire is really important for really anyone diagnosed with a cancer diagnosis that's impacted, their sexual self has impacted men and women. Really important. And also to just respect your body, especially as you're healing. You know, it's okay that by 6 o'clock you may be totally wiped out, and thinking about being physically intimate may not be the ideal time, or maybe it is. But listening to your body, paying attention to when your fatigue and pain is lowest, and using that time to explore being sexual, whether it's with your partner or yourself, can be very beneficial, because again, you're going to be in your best place and space. When we also think about low desire, we do want to treat with therapy anxiety, depression, and body image issues, because if we're not treating those in unison, it is going to defeat the purpose of helping you fully embrace your sexual self, and it ultimately won't help you fully enhance your sexual function, or at least satisfaction with your sexual function. If hormone replacement therapy is an option, certainly, as I said before, it can help with mood, it can help with addressing the menopause symptoms. But again, important to point out that although it might help improve orgasm or other sexual desires, if you notice that it's not improving your desire, and that's because you have depression, substance abuse challenges, or other mental health conditions, again, you might want to think about having that conversation with the therapist, because hormone therapy nor PDE5 inhibitors are going to help address that. We've got to address what's up here first. And as we know, cognitive behavioral therapy is one of the most effective interventions for managing sexual dysfunction and the changes in the sexual body, looking at cognitive restructuring and communication within yourself as well as your couple. So if the thought in my head when I wake up is, I know it's not going to work again for me today, so why even try? I'm going to challenge that thought when I notice that it's negative and say, you know what, I have tried hard things and I can accomplish hard things. And this is hard. It is a hard change in my body. It's a hard change in my spirit. And I'm going to keep at it. Right? I'm not telling myself that I'm going to be successful, but I'm reaffirming that I can try and that I'm capable of trying. And giving ourselves those affirmations are so important. I may not be able to get the same erection or the same orgasm that I used to have, but I can find sexually satisfying ways to engage with my body or with my partner. Very different message than I'm not orgasming the same, my erection isn't the same, therefore I'm never going to be satisfied. Just wanted to give you some information that there are, if you are having hot flashes, which is not actually that uncommon for men, that there are non-hormonal ways to treat it, acupuncture being one of the interventions that we see is highly effective and could be a tool for you that could help manage the fluctuation in hot flashes. If you're noticing that you're feeling anxious about your performance, if you're worried about how someone might receive your body, if you have an ostomy or another device, a stoma, and you're worried about how that might be received by a partner, you know, this is where, again, talking to a therapist can really help in learning techniques on how to manage that device. And how you might be able to find other ways to cover it or engage again in feeling sexy and feeling masculine or feminine or whatever it is that you connect with while still having the changes in your body. Considering masturbation prior to engaging, if you're worried about what your erection, how satisfying it might be, your orgasm, how your body's going to respond, what touching might be like again, how your scars might feel, you know, really getting self-focused and self-touch masturbation, if culturally and religiously appropriate, certainly can be helpful. And when I talk about masturbation in this particular instance, I don't necessarily mean masturbation with the goal of orgasm or ejaculation. In some ways, masturbation is also a therapy. It helps increase blood flow. We know blood flow is healing to tissue. It helps with the sensitivity. It allows for you to get to know your body again. Again, so I see it as a physical therapy prescription, as something that can help you continue to gain confidence in your body without it being set on the goal is orgasm or ejaculation. It really is just allowing your body to increase its blood flow, to see how your body responds, to see how long it can respond, and for you to just, again, get comfortable with touch or sexual intimacy. We also know that prolonging foreplay with yourself or with a partner clearly ensures adequate arousal. It helps improve erectile strength. For women, it helps improve vaginal lubrication, and for both, it improves arousal. If, as I said, you're struggling with kind of the anxiety of what this might look like in a relationship, that idea of both masturbation, but also staying really self-focused can be important. So I'll often say, get in the bath and just sit and get to know your body. Or when you're in the shower, touch yourself, see what feels good, what doesn't. What might be permissible to be touched that feels sensual? What might not? What are you not comfortable with your partner seeing, or what are you comfortable with your partner seeing? If you have scars that you're feeling insecure about, we don't have to be totally naked to be sexually intimate. So maybe it's wearing a shirt, or maybe wearing boxers. There might be something, again, that you can do that allows you to gain your confidence in the way you look, or gain the confidence in the way you feel. One of the tools I'll often use with couples is a red-green crayon technique, where I'll give them both a red-green. I said, draw a stick figure. And I want you to use the green where everything is go on your body. Like, it feels good to be touched. It doesn't hurt. You don't have anxiety about it. I want that to be green. And then red is, I'm not really sure. I'm not feeling confident, or it doesn't feel good to be touched there. And often what I find with couples is, in their projected minds, they've projected this idea that everything is bad or nothing is working. And what they find visually is actually there's just a small part of the body that maybe they're dissatisfied with, or frustrated with, or isn't working well, or doesn't feel good to be touched. But there's green so many other places. And when we think about that, just practically speaking, our mind is our most important sex organ, but the skin is our largest sex organ. So the possibilities, if we get out of our own way and think, the only sex organs we have are genitals or breasts, and we think about the amount of skin we have that have nerve endings that feel good, that feel nice to be touched, that can be sensual and sexual, there are a lot of possibilities with our bodies, even post cancer diagnosis. So Sensate focus exercises is one of the ways you can reconnect to your body. And you can do this with a partner, but I first recommend people just doing it alone. And again, in the shower or on the bed, just beginning to touch your body, seeing what feels good to be touched in ways that maybe you hadn't explored. Oftentimes, especially for people who have been in a coupleship for a long period of time, they've kind of figured out what worked for them sexually, push this button, do that, kiss that, and boom, you got it. You got to the goal. And being able to give permission to redefine that and say, let's find some new ways to see what else feels good to be touched. I didn't know that my neck felt so sensitive, or the back of my leg was more sensitive than I ever knew. Being able to explore that without the pressure of genital touching, penetration, oral or anal intercourse, all of that is off the table for the first several weeks as you just get to know each other's bodies and begin to explore what it feels like to be physically intimate and connect and just enjoy the sensual and sexual experience of touch and closeness. When we think about a coupleship and some of the challenges we see within couples, that conspiracy of silence, oftentimes partners feel ashamed to say, I miss this aspect of our life, because they feel like they don't want to make you feel bad, or they don't want it to be about them. And vice versa. You don't want to say it if your partner has been giving you so much and they're doing so much, or they're having to work extra hours at work. And so there's this conspiracy of silence. Let's just not talk about it. And it will heal itself. But the reality is the less we talk about it, the further that divide gets. So bringing back the conversation, talking about what your needs are in a way that is open is really helpful and healthy, because silence often can be interpreted as a lack of interest. There might be a perception of rejection. I'm not wanted anymore. Your partner may feel they're not wanted anymore. Your partner may be afraid of causing pain, or again, being perceived as selfish. And again, interest or arousal may be perceived or experienced differently. And that may mean, again, a difference in the strength of an erection, the ability to maintain an erection, that if your partner has not experienced that before, they may be under the belief that you're not attracted to them anymore, and that's why that's happening. So really, again, having that conversation, being able and willing to lean into some uncomfortable and hard conversations can be so important and so healing for couples. One of the tools I teach couples often is state of fact, belief, feeling, and need. So for example, and I will say, in coupleships, often we're really good at the first three. We state a fact, we state the way we believe, the way it makes us feel, and then we're really bad about giving our partner or partners an action, something they can do about it. So we kind of drop the bomb and walk away. But if we can give them the information and then give them an action, that's so helpful. So ever since my cancer diagnosis, you've touched me less and we haven't had sex. Fact. I think it may be because my ostomy is a concern for you. Belief. When we don't have sex or don't touch, I feel very lonely and I miss being close to you. Sometimes I also feel angry that cancer affects our sex life too. That's your feelings. Then the next part that we often miss is, I would feel much better if we had sex or we were intimate more often, and if you initiated more touch. So you're talking about your needs and the action that they can take. When we think about those who are single and looking at dating, or if you're in a partnership and you find that maybe your relationship hasn't involved sexual intimacy in a while, and that's not something that's going to be reclaimed in this relationship, can you still be sexually satisfied with yourself and your own sense of sexual satisfaction? So I often get from people of all ages, when do I tell someone romantically if I've had or had cancer? And I say, I wish I had that magic wand. I don't. It varies so much. It depends on who you are, how you typically tell your story. Are you someone that comes in and tells the person across from you about, your crazy mom or the kid that you've had that drives you crazy and has put you in financial straits on your first date? If so, you probably would disclose your cancer diagnosis on that first date. But if you're someone who wants someone to get to know you first, the you beyond, all the other things that we bring, the reality is, I would say by the time we're 30, we all come to a relationship with some baggage, some information. But as we come to relationships, we all come with our own stories, and getting to know the person behind that story, because you are not your cancer, you are not your sexual dysfunction, you are so much more than that. And so letting that person get to know who you are, and then introducing your diagnosis and some of the challenges it faces, but how you address it is going to be important. One of the most important things that you can do if you're wondering, how do I disclose I'm single and don't know, is be informed on what your options are. Because what's hardest is when you disclose information and they say, well, what can you do? Or what have you found worked for you? And you don't have answers. That then leads them to believe either there is no solution, or that it's not an area that you care about. So being able to come back with how you manage is really helpful often. For, again, someone that's in a coupleship, remembering self-pleasure might be an option. If it is something that you continue to desire and your partner continues to show they are not interested, initiating potentially a therapy session or seeing a sex therapist together could be helpful in identifying what might be getting in the way. Is it truly a desire discrepancy? Is there something else going on, a breakage in trust, a feeling of loss? So that can be really helpful. And again, if you're not in a partnership, self-pleasure, surrounding people who fill you up, who really meet that intimacy need, that's within your control. Finding people who bring you joy and putting yourself in situations that you feel emotionally connected to and satisfied. I would be remiss to, in any of these talks, to not talk about those who are living with advanced disease. And certainly this can be at any stage. It can be advanced disease and entering palliative and hospice care. It could be the early stages of advanced disease and on active treatment and all in between. We know that there's certainly a heightened recognition of the losses that have occurred, the things that continue to be lost. And that changes depending on where they are in a treatment cycle and what treatment they are on, or if they're starting a new treatment, that every time a new treatment is started, something new might be added to that loss. They might also find gains. But for this specifically, there may be a need to redefine sexuality and intimacy, because that redefining may be based off of side effects. It may be based on energy. It may be based on just feeling nausea. So being able to find ways to be physically intimate that may or may not involve sexual play is really important for the couple. Also thinking about how you define and set boundaries on couple time versus caregiver time, and whether you want your partner to be your physical caregiver or whether that might be a role for someone else. For some people, having their partner be their physical caregiver actually is a great way of emotional and physical bonding, and they find it to be intimate and really wonderful and beautiful. For others, they find it invasive, intrusive, embarrassing. So being willing to have those conversations too and setting boundaries. If you are in a relationship with advanced disease and your partner is your physical caretaker, take time out from the caretaker role. Sit on the couch, snuggle, watch a movie, but take time to step away from being the caregiver and the patient and go and take some time to be partners. What we know about a healthy relationship, some of the factors, the predictive factors, as we begin to wrap up our time together before questions, is a good relationship with yourself and your partner before the diagnosis leads to better outcomes. We know that a satisfying sexual relationship with yourself and or your partner or partners before the diagnosis also leads to the greater opportunity for a healthier adjustment to the changes. And again, that doesn't mean if you had a satisfying sexual relationship prior to your diagnosis and you have erectile dysfunction, that your erectile dysfunction is going to be any better. But the way you manage it and the way your relationship is able to manage it and the way that you're able to adjust actually does show to be stronger, better. Having support from your sexual partner or partners, again, your partner's sexual health as well as your own sexual esteem, how you feel about your body, right? How you think about your body and feel about your body are really important. And then again, the use of healthy communication is so critical. So to summarize, discussing issues of intimacy and sexuality before treatment and then early and often throughout your treatment is really important. Understanding what your rehabilitation options are. If you know that you're going to have erectile disorder or changes in your erectile function, learning the tools and tricks you can do at diagnosis throughout and then continue after your treatment finishes, you will have greater success and have less anxiety. Giving permission to redefine expectations as well. So, oftentimes, again, it's about what we expect and what our partners expect, and that may change regularly. And especially the first year or two after your diagnosis, that may change daily, it may change weekly, but having the flexibility and understanding that if one day you felt really good and you were satisfied with your sexual encounter with yourself or with a partner, and that went really well, and the next time you try it, it doesn't have the same impact, I would really encourage you not to get discouraged. Keep at it, keep trying, redefining those expectations and being able to understand that it's going to change is okay. Remembering that to diagnose and treat a sexual dysfunction, we got to assess a lot of variables, your psychological, your physiological, and your social, and make sure that we're treating all of them so that you get the best outcome for what you're hoping for. Knowing that a conversation with a healthcare provider can be therapeutic. And then again, for men experiencing erectile disorder, erectile dysfunction, we know that PDE5 inhibitors are certainly often greatly effective along with counseling and or combined with vacuum devices or other interventions with counseling. But the most important sex organ for humans is the mind. So again, different than what we're taught often, yet really liberating when we think about the opportunities being endless. And I look forward to an ongoing conversation with you about some of your questions and some of the challenges or experiences you've had that you want to share with others. So I'm going to stop so we can stop the recording and get into questions in just a moment.